on the 16th. All right, physiological adaptation. So for the NCLEX RN exam, it is one of the top 3 portions of the pie. So it's management, then pharm, then physiological adaptation. So it's 14%. It's the meat and potatoes of nursing. It really is. It's med surge. It does frustrate people a lot because it's what we do as a nurse. We're figuring out what's wrong with the patient, what I'm going to have to do for them as I'm taking care of them during the day or night. So it is the meat and potatoes. It's the reason you go in and you get your report. You want to know who's the patient, what's wrong with them, and what do I need to do for them today? What's my hypothesis? What am I thinking about? What's going to be their problem? The problems that I have to fix. The client needs, patient needs. All right, so it is on average 11 to 17% of the exam. All right, and then for this category, the RN is managing and providing care for clients. Basically, it's the acute problems, the chronic problems, the life-threatening physical conditions. Right, so it can be any of those things. I think tonight some of our questions are going to deal with telemetry, managing the care of a client with telemetry. Can't remember what the other ones are, but we'll see as we go along. All right, for the LPN exam, coordinated care was top, then pharm. Pharm and safety are actually tied, and that's really true. When I was at LPN, I was on the med cart, passing meds and keeping my patients safe and preventing the spread of infections, or assessing if a patient may have had an infection. Those are the top 3. So physiological doesn't weigh as heavy as safety, but it's 10%. It's still more than health promotion and maintenance. So it's 10%, a little bit less percentage. And on average, it's 7 to 13%. Okay, same thing for the LPN. You're participating in providing care for clients with acute, chronic, life-threatening physical conditions. So it can be your trach care, your cardiac monitor, recognize and report basic abnormalities on the heart monitor, the cardiac monitor strip, pacing device, ostomy care, ventilator, acute or chronic illness, identify signs and symptoms related to it. All right, so for this first question, we're going to look at, I'm just going to kind of let you read through it, but think about your test taking strategies. And if I had to add anything onto this other than like the priority and closed-ended words, comparable and alike, umbrella options, choose a nursing intervention over medical. Think of the concept in the question. Is it similar to the option? The other thing I would keep in mind is nursing actions. Because physiological adaptation is what you're going to do for the patient. Sometimes they want you to prioritize it. What's next? What's first? Put the steps in order. What you're going to do. So nursing actions. There's 2 things that you are going to think about. And then I'll also keep in mind priority. What's most important for the patient. All right. And sometimes the subject helps. I don't think we'll have any subject base this time, but that does help. All right, so we're ready for the prize. I'm going to set a timer. So we're going to look at this question, and I'm going to set a timer for 2 minutes. So if you had 2 minutes per question on a 5-hour exam, you could do 150 at exactly 5 hours. There will be some questions that won't take you 2 minutes. So you may do a minute and a half. It's safe to say a minute and a half per question. But I'm going to set the timer for 2 minutes. All right, is everybody ready? Ready to start? Okay. All right, if we're ready, I'm going to go ahead and start my timer, and just take your time, read through it. When you think you have eliminated all your choices and you're, confident that this is what you think the answer is, just put that in the chat. All right, ready? We're going to start. All right, the timer is going. We got 2 minutes. This should be just uncontrolled AFib. That was a typo. All right, we're down to 1 more minute, 59 seconds and counting. All right, we're down to 20 seconds. 20 seconds. All right, 5 seconds. 4, 3, 2, and 1. All right, very good. Very good. All right, so let's see. This was tough. This was a tough one. All right, so I don't know if you want to just break it down. Maybe we'll just see what the answer is. We'll go with the answer and then we'll just break it down. So if you answered A, you are correct. If you answered A, you are deserving of an extra tutor session. Getting tongue tied. So if you answered A, good job. Very good job. Excellent work. All right, so to break this question down, you want to focus first on your case event. And our case event was the patient had history. So it's a history of uncontrolled AFib. So not controlled AFib. All right, so they have a dysrhythmia. Atrial fib, the QRS is going to look narrow. The P waves, you can't really tell where the P waves are. They're going to look like little scribbles and they look like they're all over the place. So I probably should have put up a rhythm. I'll probably add that to the notes just so you can see. So atrial fib looks like it's kind of all over the place. The P waves are not really defined and it's going to be irregular. All right, so the nurse notes the patient's heart rate suddenly, just all of a sudden, it goes up from 90, jumps up to 150 on the central monitor. Which action should the nurse take? So several ways you can think about how to prioritize. What I would do first for a lot of questions that ask for nursing action is what would I do? I would just try to answer that in my mind really briefly. For anybody with a dysrhythmia and they have a change, I want to know, are they stable or unstable? So if I was thinking about that without looking at the questions, how would I know a patient is stable versus unstable? Where you go and check them, you look at them. You might need to get more vital signs. So the answer I'd like for it to say is check their vital signs, check their blood pressure, see how the patient is tolerating that 150 because that may guide me to know what to do next. So an action may need to be more assessment to guide you to what you should do next. All right, so nursing actions. Number one are going to fix the problem, or what can I do to help the patient, or do I have enough information to know what the problem is, or how to fix the problem. Okay. And then the second thing is how can I keep my patient safe, or is there a safety issue? All right, so several things you want to start with eliminating is I don't want to choose something that's not nursing. So option C was not a nursing thing to really do. I mean, we do prepare our patients for transfer, but that probably wouldn't be the next thing to do. What action will we take? That's going to be based upon, is that patient stable or unstable? Do they need to go to ICU? Maybe we can fix them here before transferring. The doctors are probably going to make that decision. So that was a little more beyond, a little bit beyond nursing. So that was a good one to get rid of. All right, so the next thing is D. Um, if we look at D, let's see, review the history. Well, let's look at B. B says have the telemetry tech let the nurse know of any changes. So the first thing you want to think about there is, can you let that nurse know? If you're not the nurse for the patient, is that something you can go and do? Go check on the patient or go let that nurse know they're having problems? Or do you have to let the telemetry nurse know, telemetry tech know? Now that is a delegation. You could delegate it. But remember on NCLEX, usually when they're asking what's your action, you're not going to be delegating. They'll set that aside for delegation questions. So we don't want to give, and it's kind of an important task, to someone else. Give a task to someone else that we could do ourselves. Okay, and so especially if it's the LPN and you need to let the nurse know that there's a change in the patient condition, as an LPN, you can let the RN know. Same thing if I was an RN, just seeing that on a monitor, I can go let the nurse who has that patient know that they're having changes. So that's a good one to get rid of, B. All right, so they don't really, those two, um, don't really do anything for safety, doesn't really help the patient or fix the problem. When you look at A is not really a fixing the problem action, but when you compare that to D is kind of in the past, reviewing their monitor history for the rhythm change. Well, we know they're in AFib, and that's not a bad idea to look back. When did they go into AFib? Well, they suddenly went in AFib at 8:30 or whatever time. That's not a bad idea, and it's probably some information we would give to the physician, but what am I going to do with that information? Probably nothing. I mean, yeah, it happened at 8:30. But when you look at A, and what threw us off, if you were thinking, well, we don't defibrillate, and this is where my thought was going, we don't defibrillate AFib. We defib. However, this patient does need to be on a monitor. We need to do like blood pressure. We need to put them on a bedside monitor in case they start crashing on us. And then the code card is already in there. Would this be different from on the floor? I feel like it would. And remember, NCLEX questions are not always what we see in real life. They're kind of by the book based upon what you have. If you have the choice to do these things, what would you do? And that may be how you want to ask yourself, what would I do if this is the only choice I have in life to do, only choices I have in life, what would be best for me to do to help this patient? And it would be better to just put them on a monitor. That way you got supplies, you got medicine there. If they do cold, if they do pass out, the code card is in there. We probably won't defibrillate. We won't be defibrillating AFib, but if we need to, if they go pulseless or something, we can put pads on them and we can continue to monitor them. The answer I wanted to have was looking for was check vitals. Go see them. Go look at the patient and check their blood pressure. All right, very good job. So between D and A, um, there's not much we can do with the information of when did they go into when did they go into AFib with RVR? When did that heart rate go up to 150? All right, very good. So if you got that one, A, I see a couple people had put A. Very good job. Um, it is a life-threatening dysrhythmia. AFib is not a deadly dysrhythmia. You can live with AFib, but if they're in 150, their heart rate's 150 for a long length of time, it's going to wear out, and that's where they get into trouble. It also puts them at risk for blood clots. All right, so let's see. Changes detected. The patient should be transitioned to a bedside monitor. I just want a Dynamap or something in the room. If we're not in the in a ICU, put something in there where I could run blood pressures every few minutes until we can get medicine to get this heart rate down. So we want to monitor, and provides monitoring and intervention is needed because the cart's going to have meds on there. All right. So we shouldn't delegate something to someone for an unstable patient. That was a good explanation of why not just tell somebody else to do it. They're unstable. All right. And then they have a history of AFib. We may not have to transfer them to a higher level of care because it is in their history. We just need to get their rate better controlled. Right. So it would not be the priority to review their cardiac history. All right, so we got two winners. I'm just gonna let me just take a screenshot of that so I know what answers you have.